Arrhythmia research is really, it exemplifies what I think is great about PHRI and what I think is great about everybody in this room in this large collaboration is that we can look at various problems from many different vantages. And it's really the great science and the great innovative leaps come in the overlap between many different areas. And so here are just a few of the overlaps. And I made my slides strategically like this, believing that John and Shamir and others would make comments about many of the overlap categories first. But we have very in-depth programs, not only in pacemaker and ICD population, thrombosis, as John has mentioned, cardiac surgery and perioperative, PJ, and others have led a very good program looking at this. Stroke neurology goes without saying in terms of atrial fibrillation stroke prevention, but more recently with things like how to manage patients who've had an intracranial bleed. And then on the population health side with Salim and Phil Joseph and others, looking at the epidemiology of atrial fibrillation around the world and why people die. So I think it's really these collaborations. I haven't even mentioned Jackie Bosch and Daryl Young looking at frailty in device patients and patients with atrial fibrillation. So a very multifaceted look at arrhythmias, and it's really not in isolation anymore. So a very big slide looking at some of the ongoing, I was told not to look back at previous successes, but to look forward at ongoing and future work. You can see in the top left, this has really been a cornerstone, so stroke prevention and atrial fibrillation, starting with warfarin trials, direct thrombin inhibitor trials, 10A trials, and now into the factor 11 with Pacific and other work. You can see also we have work looking at perioperative, both atrial fibrillation prevention, but also how to manage best anticoagulants in the setting of atrial fibrillation. One moves across the bottom there to that box. There's a program here called atrial fibrillation occurring transiently with stress. And again, one of the great things about working with this assembled group is the pleasure people take in busting down old paradigms and beliefs that are based on thin data and trying to move us forward with actual evidence-based medicine. So this box here talks about the atrial fibrillation that we often see when we're asked to see someone on a perioperative ward or see someone admitted to an intensive care for medical illness. We say, yes, the atrial fibrillation is probably caused by the pneumonia, by the surgery. And the question is that actually true? Or is this atrial fibrillation that we're now detecting simply because our units, our inpatient units have telemetry monitoring, and we can see atrial fibrillation that may very well have been there for months or even years before the inciting event that is often used to discount the arrhythmia and make people conclude that anticoagulant treatment is not required. If you move up into the top right, we put a lot of work, and I'll drill down on some of these in more detail into this whole concept of subclinical atrial fibrillation, and this is really talking about the atrial fibrillation we pick up with long-term intensive monitoring, which many in the room know is a very important area with growing interest in consumer electronics. And then some of the work in the top right we've done as part of a Canadian-wide and international, in fact, network looking at a series of trials to improve outcomes in patients with atrial fibrillation. So this is a 10,000-foot overview of things, and now to drill down onto some of the more important programs that we have ongoing. So stroke prevention and atrial fibrillation, again, long history amongst people in this room of moving us from an era when I started medical school where we did very little to improve the prognosis of patients with atrial fibrillation. Largely, we gave them drugs like quinidine and digoxin, which mostly caused harm and or death. Now we're in a place where John has highlighted where we can remove, through a combination of antithrombotic therapy and antihypertensive therapy, we can eliminate 80% of the strokes in patients with atrial fibrillation. But moving forward, we have new classes of drugs. The Pacific trial is a great example of this, and new populations as well. So we have recently Bob Hart and Stewart with the ESIS trials looking at the use of empiric anticoagulant therapy in patients with embolic stroke. I'll show you data on subclinical atrial fibrillation, and we have programs looking with many people in the room about rheumatic heart disease using a direct oral anticoagulant in rheumatic heart patients, and so on and so forth. Invictus, I think, is a really interesting trial. Again, we think we know a lot about rheumatic heart disease based on data which date back 40 or 50 years. It is axiomatic that we don't use direct oral anticoagulants. These patients need warfarin. However, Stewart and others are testing this in a prospective trial comparing rivaroxaban to vitamin K antagonists. It's a very big triumph of the trial simply to get into populations where these diseases are highly endemic and deliver therapy in a randomized controlled trial. And this, I think, will give us great insights in terms of the limits of direct oral anticoagulants and how this might be used. Again, when we looked at this population specifically in the AF registry, it's an undertreated population globally. Many patients do not receive anticoagulant therapy. We're dealing with a population where more than 50% of affected individuals are women, many of which are in the childbearing years. So the issue of warfarin embryopathy is relevant. And I think this would be a very good gift to the world if we can find more effective and easier to deliver therapies for patients with rheumatic heart disease. And very pleased that both the scientific will and the support from Bayer to go ahead and do this trial in this population. Safety, John had mentioned that anticoagulants have become much safer over the time. The issue of reversal of anticoagulants, it's still a very important issue, which probably applies to a very small number of patients because of the ease of simple discontinuation of direct oral anticoagulants, but much data is needed, and there still is a need to have immediate reversible available. And Stuart and John and others in the group are leading this trial looking at the reversal of factor Xa inhibitors. Now, to shift on to some of my own work, looking at this entity of subclinical atrial fibrillation. And I think this is really an important issue because implanted devices, and this is where AFib and devices kind of come together, they offer us a window. And I think as we look to monitoring technologies like PJ proposes in the perioperative setting, we've had these sorts of data available for a long time with implanted cardiac devices. And one thing they've showed us is that a large number of individuals have atrial fibrillation and are blissfully unaware. So somewhere around 1/3 to 40% of all patients we implant with a pacemaker or defibrillator will develop short-lasting atrial fibrillation over the next 2 to 3 years. And the vast majority of this, nearly 90%, will go completely unrecognized, if not for that long-term continuous monitoring. And the question is what to do about it. It's very prevalent. We've now looked outside of pacemaker populations into people just with cardiovascular risk factors in whom we implant small subcutaneous monitors and monitor those patients for 2 to 3 years and see the exact same thing, a very high prevalence of subclinical atrial fibrillation. It is associated with an increased risk of stroke. However, this risk is only about 2.5 times compared to the usual 4 or 5 time risk that we see with patients in studies like Framingham or others. It's also highly correlated with the development of heart failure, about a 4 to 5-fold increase in the relative risk of developing heart failure. And it is there, and in patients who already have implanted devices, we see the data and we just don't know how to act. And I think it is important for us to define how to act in this population of patients we already care for before we get hit by the next wave of patients, which are those who have consumer devices, smartphones, smartwatches, smart t-shirts that are going to stream to us all these small episodes of atrial fibrillation lasting a few minutes and ask the question, should these patients also be on chronic oral anticoagulants? Because when we do our modeling, looking at our studies, this probably applies to about 20% of all people over the age of 65. They would have short-lasting arrhythmias picked up if they had a continuous device like a pacemaker. So the implications on the population level are quite large. So I think it behooves us to understand what the effect of therapy, what the risk of therapy, and we are doing this right now in a 4,000 patient trial called Arrhythmias. Patients with implanted pacemakers, defibrillators, short-lasting atrial fibrillation, under 24 hours in duration, and they're randomized to an anticoagulant or an antiplatelet strategy and are being followed for the outcome of stroke. Now, this trial is approximately 3/4 of the way done, and hopefully will give us some insights in the near future because the already future are these things. Consumer devices, and many people in the room are quite expert at these, whether they're watches or smartphone devices, wearable patches, implantable devices, or some other type of consumer electronics, often consumer-facing electronics. And we're already starting to see this in clinical practice, where patients will come to us with a diagnosis of atrial fibrillation, not made by their family doctor, not made by the nurse practitioner, but because they bought the device, took it home, used it, and now have evidence of an arrhythmia, perhaps. The question really becomes, should we be screening for atrial fibrillation? Should this fall into the category of population screening maneuvers like blood pressure and other successful programs? It makes sense that it could, but of course data are still waiting, and at the present time large organizations like the US PSTF still do not advocate for screening and give it an incomplete rating based on lack of evidence. We have spun off a large international group called AFScreen, pictured down below on the left. Currently, there are many randomized trials ongoing evaluating screening using a variety of technologies, a variety of countries, and a variety of practice settings, totaling about 300,000 patients, and there's a global commitment to have a prospective patient-level meta-analysis doing all these, combining all these trials to look at the effect on stroke prevention with this. Now, shifting gears a little bit over to the surgical side, also another paradigm that's been around for a long time, never properly tested, was the idea of atrial appendage occlusion, removal, obliteration to try and prevent stroke. You know, this dates back all the way to C. Miller Fisher and the original pathologic studies linking atrial appendage thrombi with the outcome of stroke. It's been an intervention that surgeons have been able to deliver for decades, but never formally evaluated with randomized trials to see if strokes could be prevented and if there were any off-target consequences of amputating the left atrial appendage in patients who are at risk. Rich Whitlock and Stewart lead this trial called LEOS 3. It's a randomized trial of patients coming for cardiac surgery, be it valve or CABG. Half of the patients will have their appendage removed, half of them will not. Antithrombotic therapy will be continued as per clinical indications. This is a blinded study, so only the surgeon doing the procedure knows if the appendage has been removed. And over time, many of these patients will end up not receiving an antithrombotic just because of the same realities we all face with persistence of therapy in this population. So very important trial, and with over 4,700 patients randomized, randomizations complete, follow-ups ongoing, this will have 2 to 3 times the amount of data, randomized data for stroke prevention with atrial appendage removal of every other study in the world that's ever been done to date. So should be able to give us a very clear indication of what is going on with atrial appendage removal. We've also benefited a lot from networking as part of this Canada-wide C-SPIN network between various groups to look at new outcomes in patients with atrial fibrillation, not focusing solely on stroke, but also on cognitive function. And again, this mirrors a lot of what's being done in the perioperative setting. We now have 3 studies in different populations looking at cognitive outcomes and dementia in patients with atrial fibrillation. Probably the inciting study was a network study led by our colleagues at Montreal Heart called BRAIN AF. And this study is evaluating anticoagulants for prevention of cognitive decline in patients who have atrial fibrillation, but who are younger and without concomitant illness, the so-called CHA2DS2-VASc 0 and 1 patients. If they have atrial fibrillation, can we prevent decline of cognitive function? And what's impressive is if you measure it properly, cognitive function does decline in patients with atrial fibrillation, even if they're young and have not had stroke. It goes down even on an annual basis, and this has been shown already in a small 500 patient pilot. Various methodologies have been enhanced, so we screen to rule out prevalent dementia, we screen to rule out confounders like depression, using the MoCA as our primary outcome. This is what has been done in BRAIN AF. In our Artesia trial of patients who are now older and have cardiovascular risk factors, but have very mild subclinical atrial fibrillation, we're using the same battery of tests to see what impact we can have on cognitive function. And then a final study led by our colleagues in Ottawa looking at patients following atrial fibrillation ablation is also looking at cognitive function, comparing an anticoagulant strategy versus removal of all antithrombotic therapies in patients who were successfully ablated for atrial fibrillation, again, a younger, healthier population. So we'll have some indication if we can impact cognitive function And I think now we have some better tools and better ways to apply tools to study this. And just a few high-level discussions about where I think, or where the assembled group thinks that atrial fibrillation is heading. I think we are starting to pivot a little bit and look at non-stroke outcomes. We've had a very good impact on stroke, but it is not the whole story in patients with atrial fibrillation. Again, our randomized clinical trials that we've all done together and our large global AF registry are quite clear. They all show the #1 reason people with atrial fibrillation die is heart failure. The #1 reason they get admitted to hospital is heart failure. And so greater attention to heart failure outcomes is something we are beginning to work on. In many cases, the distinction between heart failure with preserved ejection fraction and atrial fibrillation with heart failure complication is quite blurry. They overlap highly. So this heart failure, I think, is going to be one of the next great outcomes we tackle in our patients with atrial fibrillation. How are we going to do that? Risk factors. We tend in arrhythmia medicine, we're very egocentric people. We think we can cure everything with a catheter and a device. And the reality is atrial fibrillation for most people in the world is not the same as having an accessory pathway that it's just a factory defect. You go in and fix it and everything's great. Atrial fibrillation is a disease of aging and comorbidity. And we neglect this at our peril, and we've not really paid a lot of attention to the atrial fibrillation world. And embarrassingly, we're paying catch up with the patients and the colleagues in the cath lab who have looked at lipids, looked at smoking cessation, looked at risk factor modification in a holistic sense. And this is what's really driving improved outcomes in chronic stable patients. And I think we need to take a page out of that book and look at targeting risk factors in patients with atrial fibrillation. I won't delve into it too deeply today, but there are some of the obvious targets, and early work has begun in this. And I think if we're going to move the needle on improving survival, right, the ablation trials, the drug trials did not move the needle on survival in terms of patients with atrial fibrillation. I think until we scratch into risk factors, we're not going to be able to move the needle very much further. And lastly, lastly, cardiac devices. I think these have been a great window into the heart and how patients do with the heart. Yes, they have a role in terms of treating people with bradycardia, tachycardia, and we've been involved with a lot of work to deliver better device therapy, large innovative trials to prevent infection, to prevent wound hematoma, a large cluster trial that Stuart led with Andrew Cron, looking at over 10,000 patients, very simple, inexpensive intervention to reduce infection. And now with some different technologies looking at how to relieve some of the other morbidity devices. So devices that do not have conventional leads that can fracture or cause trauma to the endocardium or the vascular system. So we have many innovations yet to come in cardiac devices, mainly targeting morbidity reduction rather than making more effective pacemakers or defibrillators. The last couple of points on here I think are the most important. We now use the implantable pacemaker defibrillator as a mobile intensive care unit, if you will. We can stream real-time data on many physiological parameters, surrogates of contractility, how much lung water we have as a marker of impending pulmonary edema, activity sensors, minute ventilation sensors, apnea detectors. They're all baked into the current devices that we put in, and we stream this on a daily basis here in Hamilton alone on over 2,000 patients. So we have patients in close follow-up. We have one of our trials that's taking advantage of this now. It was a trial looking at a newer type of defibrillator with no intracardiac positioning of leads. But the innovation is to finish that trial and go into extended follow-up, which we all appreciate is important, but we do this entirely remotely. So there's no patient visit, there's no patient phone call. The patients are streaming to a centralized database. When they don't transmit heartbeats for more than a couple of days, they're dead. If they have a shock or another outcome, we get this. So it's a way to have a very inexpensive long-term follow-up because the patients clinically already have this link and providing vital status. And then lastly, genetics, moving from rare to common diseases. This has been an area where PHRI and others have spent a lot of work. We have a large pan-Canada and indeed international network looking at rare diseases that cause sudden death in young people. The trick over the next 5 to 10 years will be exporting some of these learnings to get better gene-targeted therapy in these individuals. So many of the drugs that we took off the shelf years ago because of off-target effects actually have come back on the shelf as magic bullets for very specific genetic diseases. And so the whole idea of gene-targeted therapy is a real thing in genetics of cardiac diseases, in my world for arrhythmia syndromes, but potentially moving out into broader fields like heart failure with preserved ejection fraction. So with that, I'll stop being over time by a few minutes.